Boleh start
Boleh, Doktor.
Okay. So, Assalamualaikum, very good day. Welcome back. So, this is my first class with you guys for this semester kan? Hope you guys are doing okay at the college. So, if you guys have any problem dekat college tu, bagi tahu je lah any of lecturer, saya pun boleh. Tak ada problem. Saya duduk dekat je. So our class today, I will include sebab micturition ni is not a big topic, so I will include the lecture together with normal urine. So tomorrow we couldn't do the SGT, so I will give you guys a link for a quiz in Google Classroom. You guys jawab, and then we will discuss it on Friday at 12. InsyaAllah lah. Just a general discussion. The aim for that discussion is actually saya nak tengok macam mana you guys answer your macam SAQ, especially lah. For example, kalau the SAQ punya question tu tanya mechanism ke, pathway ke, explain ke, then they buat 5 marks ke, 3 marks ke, then daripada from the way that you guys answered tu, then we'll see whether it's okay, the important points is there or not lah. Kita buat macam tu. Boleh?
Boleh, Doktor.
Kalau yang SGT dengan saya, we do it like that kot. I think it will benefit you more. Then you will have a practical session on the urinalysis with the pathologist. Itu nanti you will learn more about the urinalysis lah. So kita start now. So micturition and normal urine. So at the end of the lecture, you should be able to describe the micturition process tu lah. So what is micturition? It is a process which the your urinary bladder empties when it becomes filled. So there is 2 steps. First, the bladder will fill progressively until the tension on its wall rises above a threshold level. Then it will elicit the second step, which is your nervous reflex, called the micturition reflex lah. This empties your bladder. So kalau if this fails, at least causes a conscious you have a conscious desire to urinate. Your micturition reflex is autonomic spinal cord reflex. However, it can be inhibited or facilitated by the cerebral cortex lah. Meaning that you have some voluntary control of it. It's because of the structure. We will go after this lah. Sebab bayangkan kalau korang nak terkencing tapi the situation is not permissible, tengah dalam lecture ke, tengah dalam train ke, so you have some voluntary control over that. So this is the structures that involved in the micturition. So yes, the urine is made in your kidney, and then it go into your ureter, then into your bladder. The bladder is made up of muscles. I do think you covered this during anatomy lecture. Apa nama muscle dekat bladder?
Detrusor, Doktor.
Pandai. Detrusor muscle. So it made up of muscle, so you can contract and also relax. So contraction of detrusor muscle is the major steps in this bladder emptying lah. And you have sphincter, 2 types of sphincter, your internal and external sphincter. Between these 2 sphincter, you have your prostate in males. Your external sphincter lies in your urogenital diaphragm. And as you can see from the picture, the ureter in female is shorter. So when it is shorter, it is prone to infection. Just imagine you have some very dirty outside environment. So when there is ascending infection from the outside to the inside, the infection some sort of crawl dekat ureter tu. So the female punya pendek je, male punya panjang, payah nak pergi dekat bladder. So female are more prone to urinary tract infection, especially cystitis lah. So the role of your urethral sphincter. So you have internal and external. The internal sphincter is made up of smooth muscle, so it involuntary control. It's innervated. Bila you cakap pasal involuntary, memang autonomic nervous system lah, yang autonomic nerve fibers. So it close the urethra when the bladder is empty. Your external sphincter pula, it's skeletal muscle. So your skeletal muscle is voluntary. Voluntary siapa yang jaga? Somatic nervous system. So the motor neuron will fire continuously and moderately. So your muscle are tonically contracted to prevent urine escape through the urethra lah. Itu dia punya baseline. So your bladder is relaxed and filling both internal and external urethral sphincter. So this is to prevent your urine from dribbling out. So this is your lower urinary tract innervation. So this is what the control of your micturition. So there are the lower urinary tract innervated by 3 sets of peripheral nerve lah, involving your parasympathetic, sympathetic, and also somatic. So your pelvic parasympathetic nerve, it arrives at the sacral level of your spinal cord. It will excite the bladder and also relax the urethra. And then in pelvic nerve, dia ada sensory component juga. So the sensory component will detect the degree of stretch in your bladder wall. And then you go to your lumbar sympathetic nerve, which is your hypogastric. It inhibit the bladder body and excite the bladder base and also the urethra. The next one is your pudendal nerve. Pudendal nerve excite the external urethral sphincter, and it is under somatic control, which is voluntary lah. As you can see from this picture, nampak tak saya punya arrow? Tak ada? Tak ada tu. Okay, ada dah. Nampak ya? Ada? Okay. Ting. Ada? Okay. So as you can see, lumbar sympathetic, it supply the body. Sorry, and also the bladder base. Sorry, excuse me. And then you have your parasympathetic, the sacral from the sacral plexus. It supply your sorry, it supply your bladder and also it relax the urethra juga lah. And also your pudendal nerve is somatic, which is voluntary to the external urethral sphincter. So if you see from the notes, you can actually conclude that your sympathetic is for urine retention, your parasympathetic is for micturition. So dia punya mnemonic dia dulu sympathetic storage, parasympathetic P. Ingat tu lah, nanti it will help you. And then as you remember, if you still remember your autonomic nervous system in your human biology punya lecture, so the receptors in the parasympathetic nerve is called muscarinic receptor. So the parasympathetic postganglionic nerve terminal will release acetylcholine, if you remember, which can it excite your muscarinic receptor in your bladder smooth muscle, leading to bladder contraction. And then the sympathetic postganglionic terminal, it release norepinephrine, elicit contraction of the bladder base and urethral smooth muscle, and also the relaxation of the bladder body. So it will lead to the storage of the urine. And then the third one is somatic nerve terminal, which release acetylcholine, act on your skeletal muscle, specifically. Specific receptor is your nicotinic receptor to induce muscle contraction. This is important, especially in pharmacology lah, sebab you nak tengok, for example, kalau which patient, which type of medication that act on which receptor is important. Okay, now we go to the process. So your urine is formed by the kidneys and transmitted through the ureters. Daripada kidneys keluar pergi ureters, masuk dekat dalam bladders. So how the urine flow from kidney to bladder is one, gravitational pull. Number two is the peristaltic contraction of the small muscles. Both of these help in urine flow from kidneys to bladder. So the micturition is a process of bladder emptying. It's governed by the micturition reflex and also voluntary control. So that's dua lah. So the micturition reflex is initiated when the stretch receptor within the bladder wall are stimulated. So your normal adult bladder can hold around 500 cc of urine. So after emptying, they ada residual dalam 50 cc. So at about 150 cc of the bladder volume, the stretch receptor in your detrusor muscle will begin signaling of central nervous system. Oh, terasa nak terkencing ni. Terasa macam tu. However, at 400 cc, we are seeking an appropriate toilet. So bila dia dah start 400 tu, baru kita rasa nak pergi cari toilet. Oh, dah tak boleh tahan dalam ni. So how is this reflex and voluntary control? So your bladder can accommodate 250 and 400 ml of urine before the tension within its wall begin to rise sufficiently to activate the stretch receptor. The greater the distension beyond the 400 ml of urine, the greater the extent of receptor activation lah. So when your stretch receptor is activated, it will send impulse, the afferent fiber from the stretch receptor will carry the impulse into the spinal cord and eventually via interneurons lah, which stimulate the parasympathetic supply to bladder and inhibit the motor neuron supply to the external sphincter. So, a parasympathetic stimulation will cause the bladder to contract. So, there is no specific special mechanism required to open the internal sphincter lah. So, bila bladder contract, the changes in bladder shape during the contraction mechanically pull the internal sphincter to open. So simultaneously, the external sphincter will relax as its motor fibers, as its motor neuron that supply it is it's inhibited. So now both sphincter are open. So you punya internal and also the external sphincter. So urine is expelled to the urethra by the force of bladder contraction. So this micturition reflex, which is entirely spinal reflex lah, it governs your bladder emptying in infants. So benda ni jadi especially in infants. Can babies control their micturition? Tak boleh. Pandai. Sebab tu dia boleh kencing je. Bila masa tiba-tiba je dah wet kan. So as soon as the bladder fills enough to trigger the reflex, your baby will automatically wet. Macam ni. So it is actually a spinal reflex. Dia tak payah pergi dekat, dia tak payah masuk dekat the higher center, dekat brain tu. As soon as the bladder fills tu, then the baby will automatically wet lah. However, there is a part of voluntary control of micturition. So in addition to the triggering micturition reflex, your bladder feeling also give rise to the conscious urge to urinate. Sebab kita terasa kan, kita nak terkencing kan. So sebab dia pergi juga dekat you punya cerebral cortex. So the perception of bladder fullness appear before the external sphincter reflex relax. Yang external sphincter tu. So this is a warning that micturition is imminent. As a result, the voluntary control of micturition, which you learn during all the toilet training during your early childhood too, can override the micturition reflex so that the bladder emptying can take place at the person's convenience, rather than when the bladder feel activate the stretch receptor terus kencing, tak ada macam tu. So okay, we have the control over the bladder emptying. Sorry sekejap. So if the time when the micturition reflex is initiated is there is no opportunity for you to urinate, the person can voluntarily prevent the bladder emptying by tightening the external sphincter. So the voluntary excitatory impulse from your cerebral cortex override the reflex inhibitory inputs from the stretch receptor to the involved motor neuron, keeping your muscle in the external urethral sphincter contracted so that there is no urine expelled. Tapi can you hold your urine forever? Can you?
No.
No. Semua pun mesti nak pergi terkencing juga. So urination cannot be delayed indefinitely lah, as the bladder continue to fill. The reflex input from the stretch receptor will increase with time. Finally, your reflex inhibitory input to the external sphincter motor neuron becomes so powerful that it can no longer be overridden by the voluntary excitatory input. So the sphincter will relax and then the bladder will uncontrollably empties. So micturition when you have some control on it by your cerebral cortex. However, it cannot be delayed forever. Okay. However, even we always say that when the bladder fills, stretch receptor stretch, then you need to urinate. However, when the bladder is not full or distended pun, urination can still happen. How? It can be initiated by voluntarily relaxing the external sphincter and also your pelvic diaphragm. By lowering of the pelvic floor will allow your bladder to drop downwards. So simultaneously open the internal urethral sphincter, then this also will stretch the bladder wall. So the stretch from the bladder wall will activate your stretch receptor and initiate your micturition reflex. And then with some contraction of the abdominal wall and also your respiratory diaphragm, macam you increase the intra-abdominal pressure tu, it will cause for you to bladder to empty. So what happen in urinary incontinence? Incontinence bila kita tak boleh tahan kencing. So incontinence can be divided into 4. The first one is stress incontinence. So it's due to increased intra-abdominal pressure under stress. When there is weak pelvic floor muscles, then it will cause stress incontinence. Example of stress incontinence bila ada sudden increase of abdominal pressure tu, bila orang yang ada chronic cough, ada intra-abdominal mass, in pregnancy, itu jadi stress incontinence. So urge incontinence is due to involuntary contraction of your bladder muscle where you have loss of bladder muscle control. Overflow overflow macam nama lain dia melimpah kan. Melimpah meaning that it's due to blockage of the urethra. So bila ada blockage of the urethra, for example in males, in elderly, where you have a BPH, benign prostatic hyperplasia, there is an enlargement of the prostate which may be severe enough to cause blockage. Then they will have some overflow incontinence. They can have a urinary retention and it will become incontinence if it is overflow. The last one is your neurogenic incontinence, when you have impaired functioning nervous system that control your bladder. So this is the summary of your micturition process. It involves your micturition reflex and also voluntary control. So this is the summary of it. Any question? Faham tak?
Faham?
Faham. Senang kan?
Doctor,
Yeah.
I'm sorry, but can you repeat about the overflow incontinence just now?
Okay. Overflow, bila you have blockage of the urethra. Overflow ni maknanya overflow from the bladder lah. So overflow, bila you have blockage of the urethra, so your urine cannot be emptied efficiently, even though kan dia dah the bladder is filled more than 400 mils. The stretch receptor is initiated, but because of some blockage of the urethra, the outflow blockage, so it cannot be emptied as efficient as a normal flow. So but bila at bila it reach its maximum or threshold, dia macam melimpah lah, maknanya the pressure from the bladder tu will push juga the urine to go out. Okay, faham?
Thank you, Doctor.
Dia macam you rasa nak tahan kencing, you have some voluntary control, tapi tak jumpa toilet, you tahan, tapi dia cici keluar macam tu. Faham tak?
Faham.
Itu layman punya explanation lah, so that you guys can get it. Any other question? So I expect you to know all the structure tu, korang tahu lah kan. Tapi the important parts lah, the neural control of the micturition itself, the process of is either bladder filling, meaning that bila bladder filling tu macam mana the storage of the urine lah, ataupun the micturition process, whether the patient able to micturate or not. And then you can explain the process. Okay, tak ada question? So this is also the summary lah. This is the references. Now we go to your normal urine. Boleh? Boleh, Doktor. Boleh, thank you. Terima kasih kerana menjawab. So your normal urine, there is two big criteria when you talk about normal urine lah. Is either in terms of the physical characteristic or the chemical composition. The physical characteristic composed of it's a waste product, water soluble nitrogen product lah. Chemical composition consists of water, urea, salt, pigment. Nanti kita pergi one by one. So ini laju-laju aje lah. Tapi you still need to know the clinical significance of it. So the physical characteristic, usually volume kita tak measure in urine analysis lah. Yang kalau you nak monitor the volume tu, usually kalau you perasan patient yang admitted, they have input-output chart, the nurses selalu bagi the uriner tu kan, ataupun patient on urinary catheter, dan dia boleh tengok dia punya volume. So kalau a simple urine analysis, dia akan tengok dia tak tengok lah the volume. However, what is the volume of urine you made in a day depend on the volume intake and also your daily activity lah. The term polyuria is defined as when you urinate more than 2 liters in 24 hours. Oligouria is less than 0.5 liters in 24 hours. Anuria, complete absence of urine formation. Nocturia, when you have excretion of urine at night. These terms macam oligouria ni also it comes with it can be defined as body weight per hour pun boleh juga. So there is a different definition of it jugalah. Dia boleh jadi over 24 hours, per hour boleh. Kalau dekat buat dulu, it's 1 ml per kg per hour. That is supposed to be normal lah. And then we look at the colour. So your normal typical colour is yellow to amber, but it varies according to your diet and also concentration of the urine. Concentration tu kalau you minum lebih banyak air lebih, dia akan jadi kurang yellow lah, macam tu. And then this is caused by pigment urochrome or urobilin lah. Dark urine may indicate dehydration. Red urine may indicate there is presence of red blood cells in the urine. So the first three ni, this is normal. So towards bawah ni, towards bawah ni it become more concentrated lah. And we look at the transparency. Fresh urine is usually clear. However, there is some instances when it is cloudy, when there is red blood cell, white blood cell, mucus spreads, when there is amorphous urate or phosphate crystal, it will cause your urine to be cloudy. Then you look at also the specific gravity. Specific gravity is ratio of weight of a volume of a substance compared with the weight of the same volume of distilled water. So this will provide information about the kidney, whether its ability to concentrate the glomerular filtrate or not. So the normal is 1.00 to 1.03. So kalau kita tengok, the first morning urine will be the most concentrated of the day. Sebab apa? Sebab you are holding it lama and it is stagnant for a long time. So bila the first morning urine tu, you will see it will be more concentrated lah. Dehydration also cause the urine to be highly concentrated. So kalau you minum banyak air, what do you expect in your specific gravity? Lower. Good. So this is the chemical composition of the urine. So your urine is made up of 95 and 96 of water, 4 to 5% is of substances lah. That is organic and inorganic substance. Your normal organic substance is urea, uric acid, and creatinine. Inorganic substance is your sodium, ammonium, and also potassium. So this is the normal level of the chemical substances in your urine. Your urine is sterile until it reach the urethra, where the epithelial cells lining the urethra are colonized by your gramnet rods and cocci. So urea is essentially a processed form of ammonia that is non-toxic to mammals. So ammonia yang toxic, urea tak. So urea processed from ammonia and carbon dioxide in the liver lah. And then we look at the pH also. It can be varied more than 1,000-fold from a narrow low of 4.5 to a maximum of 8 lah. So what can influence your pH of your urine is diet. Most of it diet lah. If you consume banyak sangat meat, So it can lower your pH. Citrus fruit, veggies apa semua that can raise the pH lah. Chronically high or low pH can lead to disorders such as kidney stones. Then we go to chemical analysis of your urine. So proteinuria is defined as presence of protein in your urine. So normally less than 150 milligram excreted in daily in your urine lah. If it's more than 100 milligram daily, it is called proteinuria. What can cause it? Orthostatic proteinuria, congestive heart failure, and also renal disease. Glycosuria is presence of glucose. What can cause? Uncontrolled sugars, renal disorders, and also some GIT disorders. Galactose and fructose may also be present in urine in certain inborn error of metabolism lah. Usually kita nampak dekat babies. Ketonuria, presence of ketone bodies in patient, for example, after prolonged starvation. Severe diabetes mellitus also can have ketone in your urine. How can a severe diabetes mellitus cause presence of ketone in the body is one interesting thing that I think kalau you guys baca, it is clinically significant lah. And then bilirubinuria, presence of bilirubin in patient with elevated conjugated bilirubin, in hepatic and also post-hepatic jaundice lah. Usually they are the normal level. However, when there is excessive, it is also one of the features of hemolytic jaundice. So hemoglobinuria, presence of hemoglobin, it indicate intravascular hemolysis. Hematuria, presence of blood. So hematuria, bila kita cakap, kita boleh jadi makroskopik atau mikroskopik. Makroskopik yang you boleh nampak, mikroskopik you boleh tengok dia dekat slide sahaja. Ni example of hemoglobin, how a discolored urine can be identified as hemoglobinuria or not. So you can go to this reference to read further lah about this. So when ada discolored urine, it's either it's hemoglobinuria or not. So dia jadi lain lah. So microscopic So microscopic components of urinary sediment when we see the urine under microscope. What can we see is number one, cast. It's a proteinaceous plaques formed by the coagulation of TAM-Hosphal protein within the renal tubules and wash out by the flow of tubular fluid. Your THP ni, TAM-Hosphal protein, is a glycoprotein produced exclusively by your renal tubular epithelial cells within your distal loop of Henle. So it is one of the most abundant urine protein found in mammals lah. They have cylindrical shape, broken ends, and various shape according to the tubules which they are formed. So this cast, bila cakap pasal cast, dia jadi cellular or non-cellular cast. It indicates different things lah. When you have cellular cast, meaning that they are coagulated with protein materials. Kalau non-cellular cast, it's either hyaline or granular cast. This is a type of cast that we can see under the microscope. You guys punya urinalysis punya practical face to face ke online?
Face to face.
Face to face. So boleh masuk lab ah?
Yes.
Yay. So the second one, nanti you guys will do this semua dengan pathologist lah. So crystals, your urine contain many chemicals kan. So some of these chemicals form solids. So this is called crystal lah. A crystal in urine test looks we look at amount, size and type of crystal in your urine. It is normal to have a few small urine crystal. However, a larger crystal or a specific type of crystal, it may indicate they may have some clinical significance macam kidney stones ke. So commonly seen are your calcium oxalate, calcium phosphate, magnesium ammonium phosphate or uric acids. However, kalau dia banyak sangat, it may have some clinical significance lah. This is some of the crystal that you can see under the microscope. And also, yes, cells pun you tengok juga microscopically. So you ada red blood cell, white blood cell, the epithelial cells and also the epithelials lah, dia tubular dengan squamous. So kalau red blood cells indicate apa, leukocyte indicate apa, infection, things like that lah. They have all their clinical significance. So this is some of the features that you can see in a normal or acidic or alkaline urine lah. So urinalysis is a simple test that look at the sample of your urine too. It can help in identifying problems. So there are 3 components that you see in urinalysis: visual, dipstick and microscopic. So visual ni yang macroscopic tu lah, yang apa yang you nampak. Dipstick, you see the acidity, concentration acidity, which is your pH level lah. So when it is abnormal, it may indicate some kidney disorders or urinary tract infections. Concentration is a measure of concentration lah, how the concentrated the particles in your urine. So, macam yang kita tengok tadi tu lah. And then presence of protein, sugar, ketones, bilirubins, nitrates, or leukocyte esterase, some of these ada juga. So whether there is a presence of blood. Microscopically, yang kita tengok bawah microscope, you can see the cells, any infections. Sometimes you can see the yeast, sometimes you can see the parasites, or else you can see the leukocytes semua that indicate infections, or you can see cast and crystals. So this is your urine dipsticks lah. So sekarang ni ada macam-macam urine dipstick. Kalau for example if you go to macam gynae clinic apa semua tu, they have urine dipstick, but the test is limited. For example, they want to see urine albumin, blood, specific things lah. Tapi kalau complete urine dipstick usually ada semua. I think masa praktikal ada you buat ni ataupun the proper one tu, I'm not sure lah. Tapi it's interesting and also it's very important to know. Okay, any question? Semua faham?
Doctor, is the microscopic type of urinalysis routine test that we will do? And if not, on what circumstances only we will order for this?
Okay. It depends on what do you want to see. So if you want to see a specific things in microscopic, then you will order. Tapi generally, if you when we order a test, you akan buat UFEME. Stands for UFEME. UFEM. Pernah dengar tak? Tak pernah. Urine full examination, microscopic examination. Dekat you punya lab form tu, dia ada tulis dekat situ what test that you want. You want urine dipstick, you tak nak tengok microscopic, you tak nak tengok the microscopic punya tu, then you will order urine dipstick. Urine dipstick tu kadang-kadang you tak order lah kalau dekat ward, house semua buat sendiri je. Celur, kencing, patient tengok sendiri. That what we used to do lah, tapi sekarang I'm not sure. Tapi it depends on what you want to see? What is your differential diagnosis? You want to exclude your differential diagnosis by having some information based on the investigation, then you audit. Tapi the full name for a complete urine test is urine FEME lah, full examination, microscopic examination. Okay?
Okay, thank you, doctor.
Lagi? Dah, tak ada soalan? Tu, 2, 3, 4, 5, tak ada soalan. So, if there is no question, I've created, nanti saya bagi dekat Adam Saya bagi dekat Adam. It is convenient for me to use Google Classroom. Is it okay for you guys?
Okay, doctor.
Yeah, okay, doctor.
Yeah, doctor.